I am here to give you a report on your patient. So this patient is a 38-year-old female with a right bicondylar tibial plateau fracture. She fell off of her electric scooter when she was trying to avoid an obstacle and she lost control. So her foot landed on like an uneven surface, resulting in a closed tibia fracture. Initially, she was treated with an external fixator before going in for a tibia plateau open reduction internal fixation surgery. So this patient, her only relevant medical surgical history is that she recently gave birth in March of this year, and she is just in the hospital for like post-surgery recovery here on the unit. So at the start of my shift, she reported mild pain, and her vitals were all within normal limits. Nothing concerning upon assessment, and the patient was very happy, and she seemed like very optimistic. Her length of stay, so she was admitted on July 13th, and then she's expected to discharge in roughly 12 days. So the length of stay is about 14 days or 2 weeks. So the only relevant social determinant of health is that since she just had her baby in March, she is at a medium risk for postpartum depression. So upon assessment, everything was like good. There was no concerns in regard to her neuro, respiratory, cardiac, GI, GU systems. This patient is able to move a little bit, but she notes excruciating pain while trying to ambulate with physical therapy and also when she gets up to go to the bathroom. She spends a lot of time in her bed, so this also is putting her at risk for bed sores. No bed sores were noted during this shift, but something to look out for. Also, her skin around her incisions is clean and shows no signs of infection. Her last bowel movement was this afternoon around 1400, and her last void was today at around 1530. Her mobility status is just that she can ambulate using a walker and is on standby. All of her vital signs were within normal limits, except she was experiencing a lot of pain, so this caused her heart rate to be elevated to about like 108 beats per minute, and her blood pressure was 138 over 88 millimeters of mercury. She's not on any oxygen and no use of a ventilator or anything like that. She has no IV access as of right now. And when I came onto this shift, she was experiencing moderate pain in her leg, which progressively got worse throughout the shift. So this patient was noted crying like 3 different times because of how bad the pain was. So the first problem that I was able to help with was that she reported 8 out of 10 pain in her right lower leg at the surgical site. So she states that pain is increasing with repositioning, reports difficulty sleeping or relaxing due to the pain. Facial grimacing and crying was noted. The surgical dressing was clean, dry, and intact. Mild edema was present in her foot on the affected limb, and her heart rate was elevated to 108 beats per minute, and her blood pressure was 138 over 88 millimeters of mercury. So when I was analyzing cues, I realized that her pain is related to surgical intervention and tissue trauma from the fracture and the internal fixation. Increased pain is limiting her mobility and her participation in her recovery activities, such as like physical therapy. Her heart rate was elevated, and the blood pressure was also elevated because of the intense pain. So, upon planning, my goal is that patient will have adequate pain control so that she can participate in her rehabilitation activities, such as ambulating with physical therapy by the end of the shift. And then the interventions were to assess her pain and neurovascular status, along with the effectiveness of the interventions every 2 hours, and also administer any prescribed analgesics as they were ordered, and evaluate the affected extremity and apply ice. Also assisting with repositioning and making sure to maintain proper alignment of the leg, and encouraging non-pharmacological pain interventions along with relaxation techniques, distraction, and deep breathing. So when I was evaluating her, her pain did decrease from an 8 out of 10 to a 5 out of 10. Her vital signs returned to her normal baseline, and she did participate in physical therapy, and she did have a lot of pain, but was able to complete the physical therapy, and there were no signs of any neurovascular issues or post-op complications. So the second problem that I managed was that she is a high falls risk. So she reported intense pain with movement. She stated that she was feeling weak and unsteady when she was ambulating with help, and she expresses her need for help from her husband when she was getting out of bed to go to the bathroom. Patient is limited weight bearing. She uses a walker to ambulate, and she's receiving opioid medications. So she has decreased mobility and strength in her lower extremities as well. So her Morse fall risk score was also 50, which indicates a high risk. She recently had surgical repair and has limited mobility and balance. Pain medications may cause dizziness, drowsiness, or impaired judgment, and weight-bearing restrictions may also increase the risk of losing her balance, putting her at another even further risk for falling. So my short-term goal for this patient was that she would remain free from any falls during this shift. My interventions were keeping the bed at the lowest position possible with the wheels locked and her call light within reach. I instructed the patient to call for assistance when getting out of bed, to have a healthcare worker come and help her and not just her husband. I assisted her with transfers and ambulation using a gait belt, and also made sure that she was wearing non-skid footwear at all times. Also just cleaning up her room and making sure that it was clutter-free and that there was adequate lighting to prevent any trips from happening, and assessing her use of her walker while she was ambulating to make sure that she was doing it correctly. And then patient did not have any falls during the shift, and she did call for assistance before she ambulated or got out of bed, and then she did demonstrate proper use of her walker. So some safety considerations. Her Morse fall risk score was a 50, so that is a high risk of falling. Her pressure injury risk, her Braden score was 17, so that's a mild risk for pressure injuries. So we were just making sure to do Q2 turns and had the pressure ulcer prevention in place. And infection control, this patient was educated to report any signs of infection, so redness, increased pain, any extra swelling, or any pus or anything draining from the incisional sites. And these surgical sites were being checked every 4 hours to make sure that there weren't any signs of infection. And then she was not needed to be put on any isolation precautions. The equipment that she was using for safety was basically just that gait belt and then using the walker while ambulating, which she demonstrated proper use. And then no restraints were needed for this patient at this time either. So the medications that were important to be given to her during the shift and on this oncoming shift is mainly oxycodone. So that's 10 milligrams PO every 3 hours PRN for moderate to severe pain. So before you give this, you're going to want to make sure to assess respirations and her level of sedation before giving it to her. And the patient did report improved pain control, but she was still experiencing some pain. We were also giving her ibuprofen, 800 milligrams by mouth 3 times a day, PRN for mild pain management. So before you give this, you just want to make sure she doesn't have any allergies, and that goes for any of the medications. And checking her GI history, if she had any GI issues in the past, and then helping with pain. This did help with the pain, but she still said that she has quite a bit. Aspirin is also one of her prescribed medications, so this one's 81 milligrams orally twice a day with meals. So it's given for the prevention of blood clots. So we're assessing this patient's bleeding risk before giving it to her and making sure that she's not going to have any issues with bleeding. And then so far the patient hasn't had any blood clots, so it's doing its job. Any labs that were relevant is just that her BMP that was drawn yesterday, I believe, everything was within normal limits. And then there was a CBC without differential. And this just showed that her white blood cells were decreased, her hemoglobin was decreased, and her hematocrit was also decreased. Everything else was within normal limits, and I just assumed that these were all decreased because of her blood loss during the surgery, so hopefully we can get those levels back up and check and make sure that everything looks good. Diagnostic studies that were relevant to admission. So she initially had an x-ray of her tibia and fibula. So with this x-ray, there was noted acute comminuted fracture of the proximal tibia, including the articular surface with multiple fragments. And then also she had a CT of the lower extremity without any contrast. So the surgical change status with external fixation screws were noted, and comminuted fracture with numerous fragments, as noted before with the x-ray. There was also a 1.6 centimeter fragment, which was between the peripheral lateral femoral condyle and the lateral tibial plateau. So that's something to be aware of. And also there was mild soft tissue swelling. So education that was taught to the patient was to take the medications that were needed and to maybe not breastfeed right now in order to promote proper healing. So she was really worried about the medications that she was taking, that they were going to pass on to her baby that was born in March and that they were going to affect him negatively. And so some of those medications were of concern, but ultimately we decided that it was better for her to be taking those medications to promote proper healing, and that she would just pump and dump to maintain her breast milk production, and then once she is more recovered, she can return to breastfeeding. And that this patient was also educated about her risk of falling and what she needs to do to prevent that from happening. No discharge related teaching was given during the shift, and the only social determinant of health, again, is her postpartum depression. So we did teach her that it is common and to report any signs of postpartum depression. So we taught her about some of those signs that she could report. And then the patient vocalized understanding to all of the teachings that we gave to her. So tasks for the oncoming nurse: there are no labs or diagnostics that are expected during this shift. And her oxycodone can be given at 1830, and then her ibuprofen can next be given at 2000, and then the aspirin will just be given with her dinner because that's supposed to be given with meals. And then make sure to monitor her vital signs, and if her pain has been controlled with pharmacologic and non-pharmacologic interventions, and also monitor the patient. See how she's doing like psychosocially, because she was noted crying a few times because of the pain and just saying that she couldn't do it. So just be sure to note that, and if there's any further issues with that, just make sure to provide some extra support for her. So yeah, good luck.